I'm from Northeast Arkansas. I spent the majority of my career there teaching residents until I had this great opportunity that surfaced to me in the spring to focus on my two main interests, which are women's health and preventative medicine. Today we're going to talk about women and cardiovascular disease. So earlier we saw a slide that showed that Arkansas is one of the top 5 states for vascular disease. And you'll see that this slide, pulled straight from the CDC, shows that we're the same for women specifically. We usually think of heart disease as a man's disease. That's what's taught to us in med school. All the studies essentially have been performed in men. But it's the number one cause of death in women. And, in the late 90s, only about 30% of the female population recognized this as the case. It's been consistently the leading cause of death in both men and women. Whoops. It accounts for 1 in every 5 deaths in women in the United States each year. I think something important to think about is 6 times as many women die from heart disease than from breast cancer. Every female that has breast cancer, the treatments, radiation, chemotherapy, their risk for vascular disease goes up exponentially. So we're not only thinking about breast cancer there, we need to be thinking 1 year, 5 year, 10 years down the road. Are we testing these women? Are we doing studies to evaluate for fibrosis, microvascular disease, and the consequences of those treatments? This affects 10% of women aged 45 to 64. And remember, vascular disease hits women about 10 years after men. Why is that? Estrogen. So if you think about it, endogenous estrogen causes vasodilatation. That lowers blood pressure. It protects us. When we lose that endogenous estrogen, we get into trouble. And if you also think about it, menopausal hormonal therapies are not cardiovascular protective. We used to think that, but endogenous and exogenous estrogens do not work the same way. So that's really important to think about when we're talking about menopausal hormonal therapies. And there isn't a lady that comes through my clinic to where I don't do a full vascular eval and run them through a risk calculator. And if they score greater than 5% on the ASCVD scoring, then we're going to have a serious talk, and then we're going to do more evaluation for vascular disease. The other thing I like to make a point of when we're talking about women and heart disease, our average life expectancy is increasing. It's 78. That increases yearly. Why is that increasing? Because we're talking about preventative medicine, because we have health initiatives that are providing education, and we have better, it's what the whole summit was about today. Our surgical procedures, our evaluations, our interventions, we're improving regularly. So, I mentioned that most of the research in heart disease is from men. Women in heart disease symptoms, they're unique. We do not present the same way. I think this is why a lot of us in primary care, we miss the diagnosis. We don't get women to who they need to be to our surgeons that talk to us today early enough, fast enough, because they don't have the classic symptoms. Now, I'll say something a little later that will contradict what I just said, but we'll get to that. It's my job to ask a thorough history and to know all of those risk factors. And I think generally a lot of us miss a lot of risk factors in women that are specific to women. Our risk calculators vastly underscore risk for inflammatory disease, for diseases associated with pregnancy, and hopefully we'll get more education out there and we'll work on that. Our classic symptoms of chest pain, pain in the jaw, back, shoulders, that's not what I see often in my ladies. I see fatigue, I see nausea, vomiting, sometimes no symptoms at all. And what that means is we have to work a little harder, guys, and get a better history and get these ladies evaluated. So, influencers, puberty, early or late, so many things go into that. I'm not even going to delve into that. In fact, this presentation was probably about 20 minutes longer, and I had to cut it because I could talk for quite a while about this topic. Pregnancy, especially pregnancy complications such as preeclampsia, preterm birth, especially before 34 weeks, and gestational diabetes are big risk, menopause, autoimmune disease, stress, depression, tobacco abuse. For tobacco abuse, if you had a 30-pack year smoker, man to female, the female is going to have 25% greater risk for vascular disease than the man. It's just interesting, and I don't have that explained necessarily. Acute coronary syndromes are more prevalent in females, and myocardial infarction is associated with non-obstructive coronary arteries. This is big. We talk about microvascular disease. Angiography doesn't fully evaluate the microcirculation. So we have problems, guys. I can't tell you how many times I've had ladies come in and say, I still have chest pain, but my cath was clear. I don't understand what's going on. And we've looked at them top to bottom. Well, they don't necessarily not have coronary disease. They just don't have the traditional coronary disease. Spontaneous coronary artery dissection, stress-induced cardiomyopathies, broken heart disease. I've only seen this in women in my career. I'm sure some of you have seen it in men possibly out there, but I've only seen it in my female population. So I love this slide. We all know the traditional risk factors: diabetes, smoking, obesity. With obesity, our risk in women with obesity is greater than in obese men. We're looking at a 64% risk versus 46% risk for developing coronary disease with obesity, men versus women. Physical inactivity, hypertension. So hypertension, there's no difference between men and women except for pregnancy-related differences such as preeclampsia and those things, and dyslipidemia. But what about the things that the risk calculators don't account for? Again, preterm delivery, all the hypertensive disorders of pregnancy, including chronic hypertension that affects pregnancy and causes preterm deliveries. That's a big one. Gestational diabetes, autoimmune disease, breast cancer treatments. These are all really important. Every one of us knows this risk calculator. I don't see any of those risks on this calculator, and that's where we're leaving women out. That's where we're underestimating our population and undertreating. Again, awareness is increasing. We're getting the word out there. In 2009 to 1997, women were much more aware, from 30% to 54%. The point of this is, it's proven over and over that women are less likely to receive aggressive medical therapies and prevention. And I think a lot of that starts in our primary care offices from just not recognizing the risk. Medications were less aggressive, and this is national, based off of national studies, looking at the numbers and the treatments. We don't meet blood pressure goals. I can't tell you how many times, I've had little ladies come in and, Mama's blood pressure's been running over 150, but we didn't want her to fall, but we're not doing her any favors at the same time. The other issue is cardiac rehabilitation. I found this very interesting. Women, are 55% less likely than men to participate in cardiac rehab. I think we do a really good job of this at Heart, of getting everybody in and recommending and pushing folks towards cardiac rehab, because it's really important in the recovery process. And a lot of that just comes down to the knowledge of your referring physicians and where you're at and what facilities are available. We're pretty lucky to have such phenomenal facilities. I love this study. This is the WISE study. This is a women's ischemia syndrome evaluation. It implicated abnormal coronary reactivity, microvascular dysfunction, plaque erosion with distal microembolization as causative to female-specific ischemic heart disease pathology. Females with ischemic heart disease have persistent suboptimal treatment patterns, higher mortality rates, and poor cardiovascular disease outcomes when compared to men. Some of that may be the fact that, we start later in life. We're 10 years behind men. We're not thinking about that. Women we don't complain. We don't go to the doctor. We've got to take care of our kiddos, our husbands, our families, and we're pretty busy. And now we work. So there you go. This is just something that kind of helped me wrap my head around the differences of men and women. We say coronary artery disease, it's defined as the vascular disease that's limited to the epicardial coronary arteries. And it shouldn't necessarily be confused with ischemic heart disease because they are different. Ischemic heart disease includes ischemic disease originating in the coronary arteries, the microcirculation as well, or from an imbalance of any myocardial oxygen supply and demand. In women, I like to use this terminology because it doesn't necessarily assume anatomical obstructive disease, which is really important in women's pathology. We just don't present the same way. Your biological variances among men and women are sex differences. These are expressed, on your sex chromosomes, your X and Y. And this further delineates to the differences in hormones that, result in these sex unique gene expressions and functions. This also, kind of comes down to, those issues that are associated with, autonomic regulation. I see dysautonomia in women so much more frequently than men. So essentially, this non-obstructive coronary artery disease, those patterns and tendencies among women to have plaque erosions and subsequent thrombus formations, along with microvascular dysfunction, it's not just overwhelmingly recognized or talked about. As many as 10% of MI patients have no evidence of obstructive coronary artery disease per MI registries, nationwide. And so a lot of times our patients, when they come back in, they don't necessarily, understand, especially my females who say, I didn't have any obstruction, it was clear, but why am I still having chest pain? I'm going to talk about the specific risk factors here. Preterm delivery, birth less than 37 weeks, especially if it's prior to 34 weeks. If you think about it, what's the mechanisms involved there? Inflammation, vascular diseases, coagulopathies, and infection, all the things that affect the heart. So of course, those are associated, and we're figuring that out. It's hard to do studies in obstetrics, and we just have to wait for those things to happen. But we figured out the earlier the delivery, the greater the risk for vascular disease down the road, and the earlier the vascular disease occurs. So if you have women that had preterm deliveries and they delivered and maybe it wasn't just infection, you need to be thinking about vascular disease 10 years from then. Hypertensive disorders, your increased risk, your relative risk for developing hypertension, chronic hypertension, after delivery goes up exponentially. There's a relative risk of stroke of 2.6 after 10 years. Your relative risk for DVTs, PEs increase after 5 years. The earlier the occurrence of the preeclampsia in the delivery, which is also linked with your preterm deliveries, increases your risk for vascular disease down the road. Gestational diabetes. Well, we all know about diabetes and the risk for coronary disease, and essentially if if you're gestationally diabetic, you need to be reevaluated at 6 months for diabetes. That needs to be reevaluated down the road in a year, 5 years, 10 years. Your risk goes up for developing type 2 diabetes 7 times. And so you can put those links together and follow that. Know that about your women. There's not a female that comes into my clinic that I don't talk to them about their deliveries. What woman doesn't want to talk about their births? Even if it was terrible and traumatic, they will still talk about it for 30 minutes and you'll have to change the subject. It's true. Essentially pregnancy is the only physiologic process where a person increases their weight by 20% during 9 months. And it's not how much weight you gain during delivery. And remember this, guys, there's a lot of disorders where people also gain a ton of weight and it's all fluid. And so you've got to look at a year post-pregnancy, and that predicts the risk for obesity. And remember, the risk for obesity linked with coronary disease in women is much greater than in men. Autoimmune disease. We understand that any inflammatory diseases can increase the risk for men and women, but they occur more commonly in women, and we're not looking at those on the risk calculators, guys. And so that's really important to think about. If you have someone with RA, lupus, any of the inflammatory diseases, you need to be thinking about coronary disease. And I don't care what your risk score calculators give you. Use your brains and think about, evaluating these guys, especially women, because we present asymptomatically all the time. And menopause, I'll end with this. This is the one that every lady in my clinic wants to know. So every woman that comes through my clinic, and we're talking about menopausal hormonal therapy, gets a ASVD risk calculator performed. If they have additional risk, they are going to get a cardiovascular evaluation. I'm going to send them to cardiology, or I'm going to order the studies myself, but they're going to be evaluated. If their risk on the scoring sheets are greater than 5, they need evaluation. Don't prescribe the hormones. And then also remember, 5 years out. We really thought that there was a big association with exogenous hormone replacement, and it just wasn't true. So a lot of our patients will go online to Google and they'll read and they'll be like, oh, it'll protect me. It's not the case, so be prepared to have those discussions. Any questions? Okay, thanks guys, I appreciate it.